All right, well, why don't we go ahead and get started. I want to welcome everybody to the Pioneers in Foregut. This should really be a very interesting and unique session. Hopefully you get a lot of value out of it. I think for the first time in the history of SAGES, there will not be any PowerPoint presentations. We probably could have a round of applause for that. What this is going to be is really just a series of interviews. Each interview will be about 15 to 20 minutes of people that have been sort of tapped as pioneers in Foregut. So you can sort of think of this as Foregut meets Oprah speed dating style. The whole premise for this came from Lena Catan as she was going through a process looking at how people were doing Nissen funduplication across the country. And as she was doing it, sort of all roads led back to just a handful of people. Now, for this session, we were time constraints, everything else, we were only able to sort of pick 4. But just so you know, there's many others that should and could be up here on this stage. And hopefully in years to come, we'll have more of these sessions. So I don't want to go on too long because more important people need to come up here. I do want to thank Mike Ujiki. He's the one that really did all the work putting this together. I've been nothing more than the sexy figurehead for this. So without further ado, I'm now going to ask Christy Dunce to come up. Christy, for those who don't know, was our fellow at USC, or Tom DeMeester's fellow. I was really just a junior faculty member / super fellow at the time. Christy is obviously a Foregut surgeon, and also program director of her MIS and Foregut fellowship. She completed her fellowship with us at USC, I think it was 2005 to 2006, if I'm not mistaken. So anyway, Christy's going to introduce Dr. Tom DeMeester and then start the interview interrogation process.
Great. Wow, these lights are bright.
Yes, they are.
I'm going to read this, so we have no PowerPoint slides, but I want to stay on time. So thank you for the opportunity to, I guess this is off, right? Okay.
Yep.
Thank you for the opportunity to participate in this session. It is with great honor and humility that I introduce Dr. Tom DeMeester, although he really needs no introduction, right? I mean, seriously, he has been a leader in Foregut pathophysiology for 50 years, just shy, Tom. But 50 years, his CV is 1 million pages long. It is filled with countless invited lectureships and over 1,000 publications of all different types. And then, of course, there's the DeMeester score. It is a little bit poetic that we are having this session here in Baltimore. And that is because it was here that his life drastically changed. You see, Dr. DeMeester was born in Grand Rapids, Michigan, and he was planning on going home after medical school and training and being the hometown doctor. He hadn't decided whether or not it was surgery or medicine, but he was going to go back to Grand Rapids when the dean at the University of Michigan Medical School urged him to apply to Johns Hopkins surgery program. And so he did. And he was here for many years and finally graduated. Then, after completing his military obligations, which we'll talk about a little bit later, he spent nearly 10 years at the University of Chicago, where he was part of the powerhouse team of Belzy, Skinner, and DeMeester. He was then the chairman of the Department of Surgery at Creighton for 7 years, and chairman of the Department of Surgery at USC from 1990 until he formally retired. Over the years, he has been mentor to countless people, both formally and informally. And I am lucky enough to be one of those people. The DeMeester legacy reaches far and wide throughout the world. His dedication to his fellows and generosity of knowledge has led to great loyalty and gratitude. Those of you who remember Saturday morning research meetings and 5 a.m. abstract writing sessions know what I mean. I want to take a minute to read you something that his wife Carol wrote several years ago, which I think sums it up beautifully. Let's see if I can pull it up. So she wrote this as part of a book that was dedicated to Dr. D. It is long before sunrise when the doorbell rings, the coffee is ready, and the welcoming lights in our home are turned on. This morning, a young doctor has come to go over an abstract for an upcoming surgical meeting. As I prepare breakfast in the kitchen, I overhear the conversation around the dining room table. These are treasured hours. Most of you reading this have experienced these early morning sessions, and perhaps that was part of your decision to become an esophageal fellow. For you and I both know that sometimes it took several mornings to finish the writing. When I hear the hearty laughter, I know the stories have started. It's very quiet, and I know one of the life's questions was being discussed. Who will I marry? How will I achieve my career goals? Or who is Jesus Christ? During those times, you saw deep inside a servant's heart. Each of you have enriched our lives immeasurably. If at times I could see discouragement on my husband's face over hospital politics, the joy was restored after meeting his fellows. My hope is that each of you will carry on the tradition. So, on behalf of the countless students, residents, clinical fellows, research fellows, colleagues, friends, I want to take this opportunity to say thank you, Dr. DeMeester. Will you come up? So I'll tell you guys a little story real quick while he's sitting down. When I was a fellow, oftentimes, I think they want you to sit here. Oftentimes, you would be in the operating room, you'd spend like 8 hours doing an en bloc, and you hadn't seen the patients all day long, and at the end of the day, it's late at night, and Dr. D's like, okay, we'll round in 10. And as the fellow, you're supposed to know everything. All the details, all the doses of morphine that they got through the day, what their fever curve was, how many steps they took, how many grams of protein ran in their tube feeds, et cetera. But you'd been operating all day. So you're randomly quickly gathering the team and hoping everyone has their shit together. and so one day we're rounding and we get through the ICU, and me and my two other co-fellows were like, okay, ICU went well. We go to the floor, we round through all the patients, we go to the last patient, the whole team is in the room, the lady is fine, she's happy, everything's fine. And Dr. D kneels over and he grabs her arm and he goes, ma'am, everything is fine, we'll be right back. And he puts her hand down and he looks at the team and he's like, out. So all of us walk out and we're all standing in the line, in the hallway, in line like the Von Trapp family with interns, second year, third year, fourth year, fifth, chiefs, the three fellows. Yes, sir. And he decides to walk back military style, drill sergeant, and tell us his hatred for thrombophlebitis. And apparently that patient had an extra IV in her arm that he had held and was starting to get thrombophlebitis. And so thank you, Dr. DeMeester, because now I have a hatred of thrombophlebitis too. But now it's also my turn to ask you questions. So this is a little bright, but I think that a lot of people, a lot of us, find ourselves on a path that we didn't expect, or our careers are going in a direction that we weren't planning for. And I think one of the most inspirational things that you have ever told me, the stories that you have ever told me, is about how what happened to you in Hawaii. So briefly, in the early 70s, he had just finished all of his training. He had just gotten board certified. He was going to be this hotshot, cardiothoracic surgeon. And he goes off to Tripler in Hawaii to start his career as really a cardiovascular surgeon. Can you tell us what happened after that?
Well, I was at Tripler Army Hospital in Hawaii, practicing cardiothoracic surgery. at the cardiac team. We had a cardiac team there. And this was going along fine. I was a 3-year man in the military at that point, to be 3 years there. And all of a sudden we got a notice that the Presidio, which was another cardiothoracic program in San Francisco, didn't have enough patients to train their residents. So the Army decided that whatever patients were reasonably stable and or elective could be sent from Hawaii to the Presidio. And that reduced our cardiac load to some degree. And there was extra time in my hands. I mean, the days were, we do one case in the morning or so, and then I had a little extra time. And I noticed that there was a lot of hiatal hernias referred to us. And that was unusual at that time. And so I went down to see the chief of gastroenterology, one man, and I said, Larry, why are you sending all these people to surgery? And he said, well, look at my waiting room. It's just crowded with people. And he said, I'm the only gastroenterologist here, and if they don't get better, all I got is Maalox. If they don't get any better, I send them up. And I said, well, Larry, we don't even know what operation to do, a Nissen or a Hill or a Balzi. And he said, well, why don't we try to find out? Now, he was a really aggressive, good gastroenterologist. And so we started putting together the pieces to do that study. And as I got into that, it changed my life. I decided to focus on basically esophageal surgery. Not right away. It wasn't until I went to the University of Chicago, and I can remember the day I did my last bypass. It was a quadruple bypass. And I just said, I'm putting it aside because I got a lot of referrals because of the 24-hour pH monitoring. And I decided to spend my life there, not worry about myocardial perfusion and things of that nature.
So how did you come up with, or how did you work through the pH monitoring? So you're in Hawaii, and what were you guys doing?
Well, when we got this study started, we did a study, and it's been, at that time, that was pretty new, a randomized study between Hill, Nissen, and Balzi. And we were figuring out how to test the different procedures so we could figure out which one was the best. And there was a test called the standard acid reflux test, which you put 300 cc's of 1/10 normal hydrochloric acid in the stomach, and you'd have these maneuvers that you'd have people go through. And if you had 16 opportunities with these maneuvers to reflux, and if you reflux more than 2, you were abnormal. It was a pretty good test, but it wasn't real physiological. And so we kept thinking, how can we improve that? And actually, after some discussion, Larry came up, this is the gastroenterologist, and said, look, the people are trying to do this, to have this pH probe, and that had just sort of come out, not maybe a couple of years before that, and they used it in industry, and they could measure pH, so that led us to start to keep the pH probe in there for longer periods of time, and eventually we had it in for a day, but the big problem was the reference electrode. You just had to have the patient's arm in water. So, and we finally figured that out and got a reference electrode that could work and give ambulatory ability. And
so you were monitoring people's pH. You had a tube in their nose and their arm in a bucket.
Yeah.
And so that wasn't very realistic.
That's right.
How did you get over that? I mean, what did you guys
Well, we noticed at that time that the EKG would work with people as a way of grounding, and so we picked up that technology and used it in the arm, and eventually got it to where it would last for a day and not get dry and so forth. We had a lot of help in the military to do those things, and so that's how we got it. And then I think the biggest thing that happened was So we had this data, and we could say that people were set different from each other in 6 ways. There were 6 observations we made. And how do we describe that? And this, by the way, is the reason why I think the pH monitoring has persisted. Because those 6 measurements were both acid exposure to the esophagus, as well as clearance of that exposure, which many techniques don't have. And we didn't know how to put these 6 together. So Larry said, let's go see the guys that shoot the rockets. And they had a compound in Hawaii that was testing rockets going from a base up in Northern California to Kwajaleins. And they would go over the top of them and they would fish it out and do all this. And they were kind of bored with that. And so we went there, we made an appointment, and there was about 15 of these guys that work mathematics. And we told them, we have these 6 things, and there's physiological reflux on that. And what do you think? Well, that discussion actually gave rise to the development of the score. And it's very clever. It's a very clever way of doing it, because it takes into consideration that people have a baseline reflux that's normal, and it takes into the difference in confidence for each of the 6 measurements, so that you're not skewing things by one measurement. And it's held the best of time, and it's been over about almost 50 years now that it's still used. And that helped us a lot in all of our subsequent evaluations of patients, because we could say, he's got symptoms and he's got a positive 24-hour, he's got the disease. And we began to look at it that way. And I think today, if you're really pondering whether or not a person's got the disease, pH is the way to go.
So, can you tell us about, I think most everyone has read the 86 paper about the Bougie. Can you tell us about that evaluation and how you came up with the short, floppy Nissen, and why do you use a 60 French?
Well, why what?
And why did you choose a 60 French Bougie?
You know, I missed you again. What did you say?
The 60 French Bougie.
Oh, the 60.
Compared,
okay.
So the original was a 48.
Right.
Yeah?
You got to go back into time, and you know, these 3 operations were just proposed: the Nissen, the Hill, and the Balzi. Balzi was probably the first, and then the Nissen and the Hill. And no one really understood the physiology of this disease. It was just moving anatomy parts around, and a little information about physiology, but not enough to really. So we noted in our experience that there was a significant persistent dysphagia in some people, and that was not going to be helpful in doing the operation. And if you look at the early descriptions of Nissen, his rap was quite long. And so we began to study that. And we found out, and if you read the paper, you can find out that we had to increase the size of the Bougie. Nissen started with a 36 French. We increased it slowly to a 60. And then we shortened the length of the wrap down to 1 centimeter, and that shows you the graphs how that improved. And that essentially got rid of a big problem with the Nissen, and you may get some temporary dysphagia, but it got rid of the problem of dysphagia. A lot of people don't do that, and they think they can assess it, and they continue to have an incidence of dysphagia that is discomforting to the patient. And that's how we got into that side of it. And we subsequently found that the wrap really just prevents effacement of the lower esophageal sphincter and the start of reflux at the very junction of the stomach and the esophagus. So you don't need a big wrap really for it. The rest of the wrap, the posterior part of the wrap, is a little bigger, of course, and that's important to conduct interabdominal pressure to the stomach so that you don't get a difference. Sort of makes up for having adequate abdominal length of the sphincter.
So one of the things that I find truly remarkable about you, and what makes people get out of bed and get here by 7:30 in the morning, is that you have an ability to continue to evolve your thinking over the years, to synthesize the new data that everybody's coming up with and put the pieces together so that it's fresh. A lot of people, they kind of stop at some point in their career and they don't progress or evolve. I want to take the last couple of minutes to give you an opportunity to tell us where do you think we're going with anti-reflux surgery?
Well, I think that anti-reflux surgery was kind of pivotal in the history of surgery. It was, as surgeons, we did a procedure, and it was either extirpational, usually. And so what happened after we removed something, it was just the consequences of removing the organ that you were designed to do. But anti-reflux surgery changed a lot of that. You were altering first the anatomy, and then as we understood it more precisely, you were fixing the problem inside of an organ. And you were leaving it in there and expecting it to work. And so that was a whole different approach. And it meant we had to understand how that organ worked. And so you had to have a sense of physiology to know that in order to be effective. And that's still a big problem today. Surgeons look at the case. They don't necessarily understand the problem from a physiological basis. I just sort of scribbled down here, to really do a good procedure, a Nissen fundoplication, one of the most important things, and still we struggle with today, is to know exactly where the esophagus ends and the stomach starts. That's a big problem. And many times we're operating and we're placed, we have no idea where that Nissen is in relationship, or a Lynx procedure is in relationship to where the stomach starts and the esophagus ends. And we could talk for an hour on that issue. But that's something you got to struggle with, because you misplace these wraps, you have a problem. Or if you misplace a Lynx, something like that. And then you got to understand the physiology. You really have to understand the physiology. You have to think of how do I alter an abnormal physiology back to normal? So you got to provide adequate abdominal length to take care of intraperitoneal pressure changes. So you got to make sure that gets down there and in the abdomen. And you have to have you have to stop effacement of the sphincter as the stomach distends. That's a problem. That's why they reflux after meals and so forth. And then you got to avoid dysphagia as you do that. So you need to understand each of those physiological steps, or otherwise you don't have the outcome, or it's just a outcome that you're pleased to have, but you don't really understand how you got it.
Well, we could talk forever, but our time is up.
Okay.
Thank you.
Thank you, guys.
Thank you very much. Thank you.
All right.